Hello, my name is Derek Angus. I'm at the University of Pittsburgh in the US, and today I'd like to speak to you about novel trial designs in sepsis. Here are my disclosures. It's now been many years since this paper ran in Nature Medicine, essentially lamenting the fact that after the announcement that Drotrocogan had been, or Zigris had been withdrawn from the market after the publication of the follow-up Prowess Shock trial, and at the same time, the failure to find any benefit with eritarin, a very powerful anti-TLR4 drug, despite the role of toll receptors leading to actually the Nobel Prize and playing a fundamental role in the mechanism of sepsis. This paper in Nature Medicine said, oh, woe is me. What is going on with trial design in sepsis? Despite all this understanding of the basic science, we can't seem to demonstrate that anything works in clinical trials. Now, you would think at that point that we'd start doing new trial designs. Of course, sometimes we keep doing the same thing over and over again. In fact, just this week, you saw that another promising therapy, the cocktail of vitamin C and so forth, in a very traditional RCT, failed to make any difference. Maybe the intervention made no difference, or maybe we're just not thinking about trials the right way. We do know that sepsis is incredibly complex. Thousands of genes get turned on as soon as the human host is exposed to even a whiff of endotoxin. And we know that it might not be obvious on the outside which particular set of characteristics underneath is driving the response. So two people can appear phenotypically similar on the outside, but have different underlying mechanisms. So not all sepsis is sepsis. And furthermore, we know that when one models this, for example, this paper from Gilles Clermont, we can see that putative differences in things we don't measure, like pathogen load, pathogen virulence, or underlying characteristics of the immune response, small variations in that could result in drastically different proportions of patients who would be helped in white or harmed in black by a treatment such as an anti-TNF monoclonal antibody. And so you could do two trials, and one could say, aha, the drug works, and another could say, no, the trial doesn't work, or the drug doesn't work. And the two trials looked the same on the outside, but there was just a different mixture of patients. So what can be done? Well, there's been a lot of work going on recently in trying to measure all sorts of underlying biomarkers of treatment response and looking at different kinds of patterns of sepsis patients. This is just one example here. Even using clinical markers and recombining them differently, we may see different patients. And our own group has published the Seneca study, also finding these different kinds of phenotypes of patients. Of course, it's important to understand that it's not enough to just have a biomarker or a way of identifying patients that predicts worse prognosis. What we really are interested in is predicting likelihood of responding to a drug or a therapy. The problem is it's not easy to fit these biomarkers into the trials. We don't know the drug response. We don't know which biomarker at the start of the trial is going to be most effective. We could maybe discover them afterwards, but then we have to do the whole trial from scratch in the patients that are biomarker positive. We could try to guess ahead of time. So IL-6 might be a good biomarker, but then if we choose the wrong cut point, we may fail to select the right set of patients. And some of these tests are actually quite hard to pull off quickly. Our colleagues in oncology might have 2 weeks to get the results back from a biopsy, but we have to make decisions to enroll a patient maybe within hours of presentation. What are the strategies to enrich based on a biomarker that we might see cropping into sepsis trials? Well, I would call them the hope and pray models, and I won't speak further about them today, but that's largely what we were doing before, or spread the bet model, so-called biomarker adaptive enrichment or biomarker stratification. These largely fall under what are known as platform trials. So they're adaptive trials that focus on the disease, not just a particular drug. They're potentially studying multiple therapies with perpetual enrollment and tailoring choices over time based on what seems to be working best. Traditionally, they've started in the pre-approval space in what I would call the phase 2 space. trying to find therapies that look promising enough to graduate to phase 3, but allowing you to, say, in one platform, test multiple therapies at the phase 2 level, with only a couple going on to phase 3. And the best example has been the ISPY-2 program. Here were 2 papers that published about 3 years ago now in the New England on neratinib and veliparib from the same trial, the same platform trial. And in both studies, you can see that the randomization looks like this, and you think, well, what is this? And what that is worthwhile unpacking. It's something called response adaptive randomization, and it takes advantage of learning from the trial as it goes. So if you started out 50-50 in a trial, but after 40 patients in, you can see here that treatment A is doing better than B. At this point, you're only 78% sure. You certainly couldn't stop the trial, but you could take a bet in the next 40 patients and start putting more patients into A than B. And if that were correct, then in a situation like this, suddenly you'd be done after just 80 patients instead of 400. There are caveats, however. The first is, imagine if in that second 40, A wasn't better than B. Well, then in the third set of 40 patients, the trial would swing back to 50-50. The other thing is, without getting into the detail, a 2-arm trial, there's not much advantage to doing this. But it's very interesting when you start to look in heterogeneous populations, such as sepsis with different subgroups, where you're trying to test multiple combinations of therapies, again, like sepsis. So it looks like this. You have a patient, you're randomizing, say, 1:1:1 to 3 arms. The data are accrued. They go into a pre-specified model. And that model, even while the trial is running, updates the randomization to change the relative frequency with which patients are assigned to different arms. Arms can be dropped or added, and you can have different weights for different subgroups of patients. So going back to ISPY-2, they used as their biomarkers MAMA print and hormone receptor status and HER2 positivity. Now that's already multiple different subgroups. It might look like 8 boxes here, but you can actually have combinations of the boxes. There's actually 256 different ways of joining these boxes, although there's only 255 kinds of breast cancer, because one of them is no breast cancer. Now, you can't test across 255 groups, but they specified 10 separate subgroups ahead of time from all of this. So here they were running a trial in breast cancer, but with 10 separate subgroups. Okay, and then the trial looks a little bit like this. For tyrosine kinase, it's a very complicated flowchart about which patients go in, but then at the same time, the trial is also putting into another subset of patients for the PARP inhibition. The trial begins with uncertainty about which drugs work and in whom the drugs work. And they end up finding with neratinib, it works in MAMA print, in HER2 positive, regardless of MAMA print. So you can see HER2 positive, hormone receptor negative, but independent of MAMA print. On the other hand, veliparib appears to work in triple-negative breast cancer. So this is an example of how this would work in breast cancer. And of course, now we're trying to see how these same kinds of designs can work in sepsis. One potential example has actually been going on in COVID. The REMAP-CAP program is severe pneumonia, ICU-based pneumonia, the most common cause of sepsis. It's actually testing multiple interventions within multiple different domains, all in one large trial. It's got one large overarching Bayesian model that's doing that RAR, just as we suggested, and it even was ready to instantly start recruiting patients with COVID while still also asking questions about pneumonia. So domains are the different areas where they're asking questions, such as choice of antibiotics or not. Interventions are the options within a domain, antibiotic 1 versus antibiotic 2 versus and so on, or antiviral versus no antiviral. These would be different interventions. And then the regimen is essentially the recipe or the combination of them. And you can also, as we said, in different subgroups, look at different things, COVID versus not, severe COVID versus moderate COVID, and so on. This is a global consortium of many of the big famous trials groups, like the ANZICS trials group, the Canadian Co-Care trials group, and many cohorts within recruiting within Europe, as well as in the United States. Several hundred sites are already coming on board. And one example, for example, is hydrocortisone. We saw in the recovery trial that dexamethasone happened to be looking very good. This trial, while testing many other questions, was exposing patients to hydrocortisone. And it turned out that with just 384 patients enrolled, there was already a 93% probability of superiority with fixed dose hydrocortisone, while also asking other questions simultaneously. And so this is a perfect example of one large trial can actually be addressing multiple questions. I just give you this one as an example. So in conclusion, there's a high desire to tailor therapies based on select phenotypes that we know that these phenotypes can be invisible clinically, and therefore you need fancy biomarkers to try to select patients, but you don't know which biomarkers might work, and it's not enough just that they prognosticate. They actually need to predict drug response. So that means using trial designs that can address the fact that you launch with uncertainty about both drug and biomarker. You don't know if the drug works, and you don't know in whom. Trial designs for so-called putative enrichment are what I would call hope and pray models. Like you didn't know who to study, you just hoped you made the right choice. Or spread the bet. Because you don't know who to study at first, you can enroll a broader group, but then narrow over time based on which drug is performing best in which subgroup. So these spread the bet biomarker enrichment models have been working in cancer and are really beginning to feel quite feasible in sepsis. And with that, thank you very much.